Is this thing still on?
Sounds like they heard us. We are seeing some change.
We need to continue to disrupt the status quo.
And now the work begins.
You are now about to witness the strength of nursing knowledge.
Welcome to the Gritty Nurse Podcast, an unfiltered discussion on health and healthcare. My name is Sarah Fung.
My name is Amie Archibald-Varley, and we are your hosts. Our Toronto Star and the Globe and Mail national best-selling book is available now. Get your copy of The Wisdom of Nurses today. You can get a book for purchase at any of your local retailers like Indigo or Chapters, or pick up your book online through Amazon or other types of retailers. It's also available in various different formats like audiobook and on Kindle. If you read it and you loved it, please leave us a review.
Please make sure you subscribe on our YouTube channel where you can watch our podcast in video format. Like, share, and leave a review. If you're listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, leave us a rating and review. Thank you to all our listeners and sponsors who continue to support us.
Your support makes our podcast possible, and we're grateful for the partnership and for you believing in our work here at the Gritty Nurse Podcast. Stay gritty. Homelessness in Canada and in the US has been on the rise steadily. We have a problem, but are we looking at the solutions that we need to in relation to homelessness? Homelessness is not a crime, but we've seen it being criminalized by our government officials and by the rhetoric that they've been using. We need a better solution. And I think we might have someone who has ideas for a solution for homelessness and poverty. Sarah, who's our guest today?
We've been following this guest for some time, and I'm so glad to finally have him on the podcast today. We have Dr. Andrew Boozary, who is a primary care physician, policy practitioner, researcher, and founding executive director of the Gattuso Center for Social Medicine at the University Health Network. As a driving force behind Dun House, Canada's first social medicine housing initiative, he has been a leader in integrating healthcare and housing to address the social determinants of health. His work focuses on advancing health equity and improving outcomes for underserved populations. Dr. Boozary completed his medical training at the University of Toronto and health policy training at Princeton and Harvard. He has served in senior advisory roles for policymakers at various levels of government, shaping public policy on primary care reform and pharmacare. He is also the founding editor-in-chief of Harvard Public Health Review and holds the Dalla Lana Professorship in Policy Innovation at the University of Toronto. Recognized for his impact in health equity and social justice, Dr. Boozary is a Clarkson Laureate for Public Service and the youngest physician to receive the Louise Lemieux Charles Health System Leadership Award. In 2024, Toronto Life named him one of the city's most influential people. His writing and analysis appear in high-impact academic journals and major media outlets, and he was the youngest convocation speaker for Temerity Faculty of Medicine at the University of Toronto. Welcome, Dr. Boozary, and thanks for coming on the Gritty Nurse Podcast.
Thank you so much. I've been following you both and all of your amazing work over the years. So really honored to be on the podcast and be able to have this conversation together.
Yeah, and so I wonder if we could just start today by you telling us how you really became interested in the social determinants of health and housing initiatives.
Yeah, I mean, I think when, I think you put it as the social determinants of health, right? And I think it's not as known, I think, for people or the general public, what that really means. It's a pretty academic term, I think, for things that you see in your frontline work and that we've seen around what I've started to see as the pathologies of poverty, of the realities for people that are denied access to housing, which you mentioned, but really to food security, for income, to high quality care or access to even basic primary care. And we know that there is real serious fault lines when it comes for racialized and low income communities, even when we talk about a universal healthcare system in Canada. So I try to really push for us to make real what the social determinants means, because it's a kind of sanitized version of the realities that we know that result in people living 20 to 30 years younger or dying 20 to 30 years earlier. And that's, I think, really some of the work that we're talking about today and the work that we've been doing at the Gattuso Center for Social Medicine. I mean, my entry into it, I think, is probably from birth, really give a lot of my, any credit to my mother and family of growing up in St. Jamestown, of them being refugees and immigrants and growing up in social housing. And so I think that was sort of my honest foray into the realities of this being about policy choices and not really individual failures or really a lot of luck for people and for families, and where, my family had some favorable outcomes that, our friends and neighbors did not have the same. So I think early on, seeing that definitely shaped my view of the world when it came to trying to think or talk about these issues, but then really what we need to be doing about them. And I think some of this conversation in terms of the solutions and these policy solutions that we're really advocating for. So, and then in medical school, again, I was really fortunate and honored to have mentors throughout my medical training from the first week with Wendy Muckle, who's a nurse and just received, I believe, the Order of Canada far too late. I think, was deserving years ago, but never too late on these things. And Wendy being just a force and taking me under their wing in the first few weeks of medical school alongside Dr. Jeffrey Turnbull when I was a medical student in Ottawa with Inner City Health. So I think from both the personal piece, but then early in the training, I think this sort of collision was meant to happen, whether I knew it or not at the time.
Yeah, no, thank you for giving us that overview of explaining what social medicine is. I think a lot of people, I mean, I have to roll my eyes. You probably know where I'm going, because some people, when people hear social or they hear, socialize, they come with various different connotations. And I think it's really important that we explain what it is that social medicine is looking at. And I think that, one of the things that you mentioned, even like in your childhood growing up and seeing poverty and being kind of a part of poverty, is the fact that my husband said something to me the other day, and he's like, you're one step or one accident away from being in that person's position, because he worked in social work and he's seen, for example, it could be just a car accident, it could be someone that attacks you, it could be just you lose your job on, with what's going on with the economy. And people don't really realize that, like, anybody is one step away from potentially being in the position that we see people who are struggling at this point in time. And again, I think one of the things I do want to bring to the forefront is some of the statistics that we've seen, not just in Toronto, but just in Canada and, in the US, about homelessness. So some of the stats I've seen is in 2023, about 32,660 people in Canada experienced chronic homelessness. And again, those numbers are continuing to increase. And what we're seeing typically is families with children are the fastest growing homeless demographic. And I hope you can speak to whether these stats are accurate in terms of what you've seen. And again, that we're seeing that there's a rise of homeless youth. I saw this stat from the CBC that it said something like more than 80,000 people in Ontario were homeless last year. And that was a new report from the province's municipalities. And I think that's a staggering stat. And that's really concerning. And again, like, I don't want to compare the numbers. Again, in the US, it says there's something like 770,000. Again, their population is quite different. But again, we're just seeing this increase. And for example, they said there was a 32% increase. Can you comment on some of the things that you've heard? What do you think about the state of homelessness in the past 5 years and what you've seen and what you've experienced?
Yeah, thank you for those statistics. I mean, I think you're absolutely right. They're staggering. I would go even a bit further, and I say the state of homelessness is damning in Canada and the United States. Let's be really honest and call it out. I mean, the stats become so astounding that they can become numbing. But these are the realities that people working in frontline healthcare, whether it's social work, nursing, or medicine, see every day. And the realities on the data, let's be also very clear. When we talk about homelessness as one of the most powerful social determinants of health or pathologies of poverty, people who are chronically unhoused live half as long as the general public. So that's actually 30 to 40 birthdays that people would give up. Or if you think of
Right.
it from a therapeutic intervention, if we knew that there was a drug that could restore 30 to 40 years, you would think every funder, investor, level of government would be tripping over each other to
Yeah.
invest in it to ensure that we could ensure longer, healthier lives for the tens of thousands of people that you mentioned when you look at the recent reports on, especially for young racialized women with the structural vulnerability in the shelter system or in the encampment system, the realities of people not having the safety of their own home. That continues to play out across the city, across the country, where we're also seeing higher healthcare costs, unsurprisingly. If people can't access healthcare earlier upstream, their health conditions worsen, they have worse health outcomes, and that's more costly both to the person and to the system. So, I say it's damning too, not to be sensationalist, but the realities are, I think, for the three of us and, anyone listening, many were involved in trying to bend things a bit better towards something better in the pandemic. And there were some moments and pockets of hope, especially when it came to the homelessness crisis, that people were seeing it. There was this mobilization to move people into hotels, repurposing hotels as housing, not wanting to see the infectious disease spread of COVID in communities where there was really this emphasis on physical distancing. And of course, how could you physically distance if you didn't have access to housing?
Right.
So that became kind of, brought to the forefront of the pandemic response. And it's, only been a number of years and it feels more polarized. There's more encampments. There's less willingness or this belief that we can actually end and solve this wicked problem. And I think that's why, efforts like Dunhouse that you've mentioned or other partnerships um, is what we're trying to push to try to build some will and hope, given, how bleak it can feel when you listen to those numbers.
Yeah, I think that's really important because I think about in healthcare when we treat someone, right? We give them this list of things they have to do, but I feel like when you're homeless, you can't do half of them. Like you can't shower, you can't dress your wound, you might not be able to find somewhere to fill your medications. Like there's just so much that we assume people can do that they can't do if they don't have a home. And you mentioned a lot of homeless people are being housed in hotels, which I feel like obviously that costs a lot more than giving them a place to live. So I know that a lot of times we say that homelessness is not just a health crisis, it's an economic one. Can you touch a little bit on what you think about that?
It's a great point around both the health and economic benefits to housing. And I think we really need to bring both into the conversation, given the realities of what we've talked about, of where we are a few years later. And so I think those efforts to house people in hotels were well-meaning and the right thing to do at the time. The challenge is that the costing of that was also not sustainable. And I think we needed to look at converting both hotels and shelters into housing. Because the other thing that people conflate, I think, is that they view shelters as a housing option, and they're not housing options, right? They were always built for very short term to maximum intermediate transitionary spots for people to recover or stabilize and get back into a housing system. And that's no longer the case. And so, to your point, that people are now chronically unhoused or living in a shelter system for years, it shows that how anachronistic the shelter system is today in 2025, and even the hotel system. So, on the cost breakdown, which I think it's important to unpack, it's over $30,000 a month for someone to stay in a hospital bed in any downtown hospital, right? And
Right.
that's also important, that it's not that people want to be there. They're languishing in a hospital bed. The outcomes are worse. Their health outcomes become worse. And it has real serious health consequences and system consequences at the same time. When you look at the prison system, it's about $13,000 a month. And a dear colleague and friend, Lana Fredo, calls the prison system the de facto mental health system because people cannot access mental health care and end up in the prison system. And I've had conversations with patients who will say that they, have looked to throw a stone or rock through a window to be arrested because they'll actually finally get access to some warmth and care and some supports, which they were just not able to get out on the street. And again, when we talk about this being damning, I think that's a pretty clear picture of where we are when it comes to accessing a compassionate health system or social system. It's about $6,000 to $7,000 a month, Sarah, to your point around the hotels, to shelter system, and less than $4,000 a month for supportive housing. That's supportive housing, right? That's with supports in place. That's with whether it's some mental health casework, potentially access to some other navigation supports that are really helpful for people. And when people say, can we really afford more done houses, or can we afford supportive housing or housing for all, or what is housing as a human right going to cost? My argument is we can't afford the status quo. When
Right.
you look at that
Yeah.
cost breakdown, those are the realities. That's what we're paying today. And we're getting terrible health outcomes for people, which we've talked about. And we're seeing people, it's not sensationalist. People are dying because of lack of access to housing every single day. And I think that's the urgency of the work.
Yeah, I'm glad you touched on all those aspects too, because I think one of the things that people don't understand about, whether it's a shelter or whether it's, prison, is again that continues to affect someone's health care. For example, I had a cousin who was experiencing homelessness, and they talked to me about when they were in some of the shelter systems in Toronto, and he talked to me about, having to protect his things, having to he's like, you can't really sleep because you're afraid that someone might take your stuff, or someone might, attack you, even in the shelter systems, or even like, let's say it's a prison, it could be those same types of effects. So again, we know that in those places, it's not even safe for them all the time. And again, when I think about
Absolutely.
women, I think about when I had the opportunity to work at Mount Sinai, and we were dealing with pregnant women who were precariously housed, and how some of them came to be pregnant was because of, they were in a homeless situation where maybe they were raped or they were abused. And again, we this is unconscionable that we are in
Unconscionable.
situations where we can help, um, and our governments just don't get it. So what would you say is the biggest challenge? Again, probably thinking about policy. Like for me, it's like, okay, it's a no-brainer. You just explained what the costs are,
Mhm.
but there are challenges and barriers where we continue to hear through news reports, just even 2 weeks ago, about Doug Ford talking about, criminalizing encampments. Why are there these
Yeah.
barriers, and what are some of the barriers you see to addressing equitable housing?
Yeah. I think unconscionable is bang on. I think just to pick up on Sarah's point too about, and your point, about, being able to store things or not be able to, your belongings not being, I mean, imagine, trying to then also think about taking your medications for 5 or 6 comorbidities or health conditions, right? From diabetes to mental health issues to cancer treatments. That's the realities for people in the shelter system. It's hard enough when you have your own place and you're dealing with work and all the other things that are in place and the supports that are in place. Imagine all of that without it. And then the way we as a medical system view it is we write in our charts, of course, patient is non-compliant with medication regimen,
Right.
which is why they're failing diabetes treatment, uh, or they're having, poor A1C control. We don't write these are deaths due to policy failures, or what we're seeing is a system failing people that makes it virtually impossible to even think about taking their medications or accessing really basic care. But we talk about non-adherence and non-compliance and people
Yeah.
not being a good patient. So I think from an individual patient perspective, there are these barriers that we're talking about. I think from a policy level, which you were alluding to, I think what's hard about this issue with housing and homelessness is that the numbers make a lot of sense, but I think there's still a lot of stigma and bias and discrimination towards people living in poverty.
Yeah.
And a lot of it is what we see is even when there are housing options available, there's a lot of administrative sludge, a lot of paperwork and barriers that would be hard for the three of us to try to figure out how to complete, let alone again for someone who's contending for their life day in, day out, or trying to avoid being in the middle of violence or not being able to access, Wi-Fi. These are the real challenges that people are facing and these barriers that are very insidious that play out within the system. The other part I think is really And so I think that leads to this inertia that there isn't this real willingness to act. There's not a major government lobby and stakeholder and advocacy that's day in, day out at various levels of government. And that's why I think this work and this advocacy from health workers is important in solidarity with people who are surviving homelessness, with community providers, with people in the housing experts and policy experts. So it's not to take over as healthcare workers, but we have to be clear about how we can better advocate together, be clear and sure about what those solutions are, which is not more shelters, it's more housing options. And then I think finally, and the third point on this is that it does require every level of government to solve this problem. You need the city, the provincial, and the federal government. And I think what has happened is, and this is a nonpartisan take over, let's say, the last 25 years, there's been this shirking of responsibility from the city to the province. The province says the city needs to solve this. The city says, well, the feds need to solve this issue. And it goes back to the point around where we saw some pockets of success during COVID, is that every level of government came together and was like, we're going to mobilize a solution. Again, it's not a sustainable solution, but we're going to ensure that there are thousands of hotel units for people to physically distance and help prevent the spread of COVID and the outcomes, the terrible outcomes, which even with those efforts, by the way, early on, there was some really good research by Lucy Richard and others that showed people who were unhoused were 5 to 10 times more likely to die during the pandemic. Unsurprising, but again, speaks to why those urgent actions were so necessary as life-saving interventions. But that was with every level of government coming together. And that's hard in our system to do. There's always these challenges of the alignment of every level of government to come together, to invest together, to look at what the scalable options are. But we did see that with Dunhouse. We did see every level of government invest for these 51 units that were built on public land for people who've been unhoused. And so that, I hope, is the model that we can try to push for policymakers, and again, of any party, to say, look, whether you believe in this from a fiscal perspective, economic perspective, human rights perspective, there is alignment on this issue. And we need to ensure that if we don't act today, there continues to be lives at risk.
Yeah, and I always want to challenge the language that our constituents and our policymakers do use, right? Like I think some of the aspects that are concerning is, for example, they're using language that they used like in the 70s about like pulling themselves up by their bootstraps and things like that. And it's like none of that language or rhetoric actually explains what the underlying issues are. Or again, circling back to those social determinants of health and really kind of focusing on what the issues are as opposed to politicizing it using this type of negative I would say derogatory type of language.
Mm-hmm. And you just
Yeah.
mentioned something about, sorry, go ahead.
No, I mean, that's what we said about the discrimination. It's so real towards people, and which lives matter, that we see play out. I think you just nailed it around this lack of willingness to move, to act. There is that element that's there. And I think the storytelling actually on this is really important for people to see the humanity that's there. Unfortunately, the onus is on people surviving homelessness, but really, I think going back to what people can do to better understand, I think your, personal conversation with your husband, I think was also really, pertinent around the fact that there is such vulnerability, that we are not that far away, whether it's from our beginnings or towards our end. The realities are that, these are also health consequences that can push people to it. I mean, when you look at the realities about housing and health, let's also be clear that this is bi-directional. So people who have poor health, which we shouldn't understand in healthcare, would never judge someone for having genetic disease or any other disorder that comes into play, that we understand that that's not the fault of the individual. They're much more likely to be precariously housed or unhoused because of having poor health. And if you are precariously housed or unhoused, you're more likely to have poor health. So this really runs both ways. And that really is where we see a lot of vulnerability for people, where, especially in the United States, which you've referenced, the leading cause of bankruptcy is medical debt.
Yep.
So would you ever say that, well, your partner, God forbid, or, my partner has, cancer, and you have to, for treatment, lose your home, do what you need, or for your children, or for your family member or your parents. Leverage your any assets you have, um, and see yourself within the realities of facing homelessness because a loved one had a terrible diagnosis. So but this plays out too when you look at mental health conditions, when you look at issues that come up with respect to accidents and physical health that comes into play. So I just really think it's such an important point. We talk about the vulnerability, and especially for those of us having this conversation very much within the healthcare realm, that's what I really hope we can drive home.
Yeah. Yeah. And I think we've been talking a lot about numbers and statistics, but I want people to remember that these are actual people with stories, right? Like I follow Kathy Crow, and every once in a while she'll post on Facebook that she's attending another funeral of someone that she knew through her work that's homeless. And I think everyone has their journey to get to where they are. And we shouldn't paint people who are homeless or unhoused with a brush, like, they all look or act a certain way. And I think also, we're overcomplicating things. Like we've said a couple times now, the solution to this is to give people housing. It's actually better for them. It's cheaper. Like I think on all fronts it makes sense. And I even think about Maslow's hierarchy of needs, right? Like housing and shelter is at the very bottom. It's a human right. And like what would you say to someone who doesn't think that housing is a human right? Because it obviously is something we all need.
Yeah, and Sarah, firstly on that, I think let's take one moment to shout out Kathy Crow. I think has just done, incredible work as one of the original street nurses, OG street nurses of
Yeah.
making sure that people get access to care. And I think, again, the nursing profession has been at the forefront of housing and health for decades. People like Kathy and Wendy and many others, who refuse to let this issue go away, or people be nameless or faceless, as you mentioned. So I think, that recognition and acknowledgement, I think just has to be there, given those of us who are working in these spaces. And then I think the part about your question about housing as a human right, I think for someone who doesn't believe it, I think the flip question I would have back is how is housing as a commodity working out for you and for
Right.
everyone?
Right.
How is the commoditization of housing and the free market, quote unquote, working for housing when rents are soaring 30 to 40% in the last 3 years? People who, again, going back just to paraphrase the language, the discriminatory language, well, if people had a job, they wouldn't be in these situations. And the reality is that if people just had jobs, there would be no homelessness. Well, how is that working out for all the folks who are working really hard in certain jobs, in low wage jobs that we called skilled workers, rightfully during the pandemic, who are now one paycheck away from being evicted or unhoused? Like, what did they do wrong? How is that system working? How is the commoditization of housing working for all of us, when it's impossible to either, get rent, to buy a home? Look at all of the challenges that are now coming up around the stressors for families around even just paying their mortgage. That is going to come into play, talking about how this is so much more pervasive. So whether you're living in an affluent neighborhood, whether you're living in a low income neighborhood, I don't think the housing system is working. And so that would be my pushback on, anyone who doesn't believe that we need housing for all. And I think that's really the reality that I think we're contending with right now.
Yeah, that coupled with like the capitalism or that we're seeing, in combination with some of the rhetoric, or even just people saying, well, why is that my problem? Like that's not my problem. Again, kind of I'd say just putting blinders on, or putting their hand up and saying, well, it can never be me. And again, like I said at the top of the episode, it definitely can be you. And I think that we have to continue to call these things out. And I think it's important that I'm glad that we're having this conversation, because we don't hear enough about the stories and the realities of of poverty and homelessness. But there is a little bit of a silver lining, in terms of there is some work happening. And I don't think a lot of people do know about Dunn House. So could you maybe tell us a little bit more about Dunn House, and maybe we can see some more Dunn Houses coming up?
Yeah, I mean that's definitely been the hope. And the one piece, if I could also just add, because I think you raised a great point around some of the histories or about, the policy choices that we've talked about. So, and this is back to your question too, Sarah, around, someone who may not believe that housing is a human right or that the system is potentially working or working better if we go a different direction. About 40 years ago, again, during the 80s even, when we saw this, push around free markets and this idea that that would be more of the solution, we still saw about 15 to 20% of all housing options had a social component or a public component. There was public housing,
Right.
that there were options for people who could access housing in ways that is just impossible right now. So when you look at the percentage now of public housing or social housing with respect to the housing inventory, it's less than 3%. So
Wow.
when it comes to the reality that people cannot access, and we started the conversation about these policy choices and individual failures, this is a completely different landscape when it comes to housing from a complete policy decision that has been subsequent, right? Has been this atrophy of housing from 20% to less than 3% has taken place over the last 40 years. So every level of government, every subsequent government, we've seen this drop. And it's something that, again, why we need every level of government to really restore this investment. And this isn't a left-wing think tank talking point, by the way. Scotiabank, a major Canadian bank, issued a report saying we need to double the amount of social housing in the country. It's good for the economy, it's good for health. And even if we doubled the amount of social housing, we would still just be under the OECD average for our peer countries. So I think
Right.
that's really important to have in perspective around there are impossible choices for people because of the lack of investment in public housing, not because people are refusing to get jobs or is this a drug use issue or this is a laziness issue. This is the realities in 2025. And we look at what the private rental markets are, it's impossible for
Yeah.
people with various wages to get into housing like that. So on Dun House, this was an effort to try to better address the issue that about 50 or 60 patients at UHN made up over 4,000 emergency department visits in a year. And
Wow.
now the reality was they had nowhere to go, or as we talked about, health conditions became exacerbated, they worsened, and the risk and needs for hospital admissions was also getting higher and being readmitted because there was no real stable housing for recovery. And so with the City of Toronto, the United Way, and Fred Victor, which provides superb housing support and has been a real leader in this space for over 100 years, we were able to dedicate a hospital parking lot, which is public land, and leasing it to the city for 49 years for $1 to be able to have the rapid housing initiative from the federal government, provide the capital infrastructure for 51 housing units for this four-story building. And then we're able to see Ontario Health and the province provide healthcare supports, and the City of Toronto being able to ensure the uh, running, operating and running of Dun House with Fred Victor. And that's where we've seen, again, the now people have all moved in, where we've seen the supports that are there from a health and social care perspective. So having caseworkers that are working day in, day out with people who've moved in. I'm there clinically, so I was late every week. We have a psychiatrist who works there as well every week, and looking at some of the different supports from virtual emergency department to different outpatient supports that are in place for people. And that's where we're hoping to take this expanded version of supportive housing or this real comprehensive take of supportive housing for people who need it most.
That's amazing. That's really inspiring. And to know that you did this and you're providing all of these people now with the resources that are so desperately needed, including psychiatry and your clinical support as well. So, for anyone who's listening who feels like they don't have a voice or they don't have a platform, but they want to help, they want to make things better for people who are homeless, what do you think the average person can do that's listening to this?
Yeah, I think whoever's listening can do so much. And I appreciate anyone who's listening and has already felt either the injustice or has already been doing things of whether it was encampment support or writing and just listening, I think to better inform themselves of these issues. Uh, I think there's a huge amount of potential. One, from writing various levels of government. I think, we see city councilors to members of parliament to members of provincial parliament. I think being able to get on their radar, and I think people, listen to people living in various constituencies to really be able to write about why this issue matters. We see the opposite happen a lot when we talk about NIMBYism. There's a really mobilized, effective group that's, in various parts of the city that don't want to see more housing density or don't want to see people unhoused move in. So we really need to see a coalition of people wanting to see more housing options for people. And to me, there are no average voices on that. People who are speaking out saying that they want, neighbors to be able to access these same supports or be able to access housing, which has been denied, I think is very powerful. And I think there's a real opportunity for more of our voices together. Again, we talked about there isn't really for people who are unhoused a majorly funded advocacy group or lobby group. And so really it's on us of being able to work together as a coalition to try to advance this issue on the radar. I mean, we see it, and there's been many folks who deserve, heaps of credit of trying to get this issue on the political agenda when it comes to elections. And I think there needs to be even more of that, of how we can ensure that both from the writing, from the advocacy campaigns, that this can come into place. And then I think there's other ways of, again, working or volunteering with various community and housing agencies that have a lot of knowledge in these areas. From there's Indigenous health run housing to folks like we mentioned, or organizations like Fred Victor, to Loft, to the neighborhood group, Parkdale Queen West Community Health Center. There's so many groups that need support and help that are doing and fighting this very much locally, but also on the larger level. So wherever they can help support organizations like that, they've been in this good fight for decades, and I hope we can continue to build some more solidarity in getting these issues on the map.
Yeah, no, thank you so much for having this conversation with us. And I think we've highlighted so much good things that can be done in terms of supporting, bringing awareness to. I hope this episode will bring more awareness to the issues that we have related to homelessness and poverty, and that everyone can take something away, that we can all be a part of the solution. We can, like we can vote, we can learn more about
Yeah,
the issues that we
good point.
see.
Vote. Yeah, that's a great thing. People would
Please
vote. I
vote.
think you
Yeah.
nailed it.
Yeah.
That's a great answer. Yeah.
I mean, I think that when people feel that they can't do anything, voting is so important. It is literally your civic right to say, here's how I can be a part of the solution. So again, we always urge people to vote. I'll leave it with this last story, and maybe if there's any extra things that you want to add, that'd be great. Of I mentioned my cousin who was suffering through homelessness, and it was at a time where he ended up getting a traumatic brain injury. So he was injured. He was attacked at a bar, and the policy that was in place previous to the government that we had now was, if you were a victim of a crime, that you would get actually some support from the provincial government to get you back on your feet, because obviously if you've been hurt or injured, you can't work, but this subsidy would kind of keep you going. And with the new government, that was removed, so it made his situation even more difficult. So he couldn't access housing. He was unhoused for quite some time, and he was unhoused with the traumatic brain injury. And as much as our family tried to help and support, we could not help but see that the decisions people make based on policy alone can, really affect someone's health and their life. And again, this is why I say to people, you really need to look at what your politicians are saying. What are I guess those social safety networks that people say, oh, that's too woke, but that could be something that can end up saving your life. And I think that's why I tell people it's so important to, be involved and understand what's actually happening, and then make sure that your vote counts and make sure that you get out in there and you do the work that's so important. So I just wanted to share that last story. But with that, Andrew, is there anything that you'd like to add?
No, well, thank you for and being vulnerable to share that story about your cousin. And obviously, I hope things move in a better direction again around the policy choices that again were no fault of their own. And I mean, I think for me, just really grateful to have this conversation. Obviously, following your podcast, Amie, you and Sarah, for the last few years, and I think really being able to have this conversation with people who have been pushing for a fair health system, for fair outcomes, and just again, with Dunhouse, I mean, I think it's an effort. It's I hope an important one to try to show that things can be done, that we can see some momentum and try to build some hope. And really, this is about scaling these efforts, and I think it's kind of scale these conversations. And so I think you also just really hit it on the head around, I do think it's hard with both social media and a lot of things happening of where people are in almost two separate echo chambers. And I think the only piece I would put forward is for people to try to just look at some of the facts and not be totally run by the algorithm that is running all of our lives and based on what's on our feed. And I think on this one, on homelessness, to step back on issues, whether it's your cousin, your loved one, your distant cousin, I mean, the realities are, or a neighbor, this is something that is affecting every partisan voter, every person, regardless of which neighborhood you live in. And so, I really hope that we can see that there are concrete solutions. There are also ways that people can lend their advocacy. There's ways that people can lend support. And that really, for those of us working in the healthcare space, that we can't abdicate this as a lane, that good housing is healthcare, that housing as a human right, housing as the importance for health, that we don't back away from those conversations, because there is not a well-financed advocacy or lobby organization that will do that work for us. So I just really appreciate being able to have these conversations and hopefully getting more and more of this thinking or people's critique even out there when it comes to a wicked problem like homelessness and health.
Yeah.
Thank you. Thank you so much. We have learned so much from you, Dr. Boozary, and I'm sure our listeners have as well. So as we close with this episode, if people want to learn more about you or about Dunhouse, where should they go?
Yeah, I don't know if we have a website. It might be up at UHN Social Medicine or coming soon, that would capture some of the work. And of course, happy for people to reach out directly if there's ways, or they're my email, and I can't even remember any of the social media handles, but hopefully they're there. But if people want to reach out, again, happy to see how we can be helpful and connect folks. But at the UHN Social Medicine website, should be up imminently before this is even posted. So
great.
Okay,
check that out as well.
We'll put them in the show notes. And if you just Google Dr. Andrew Boozary or Dunhouse, that's what I did. I know things will come up. So not to worry.
Okay. Thank you. All right. Thank you both again.
Yeah. Thank you so much for coming on to the Gritty Nurse podcast. I know you're busy, so have a great day. Thank you for all of the great work that you've done as well.
Thank you.
Really appreciate it.
Thank you for listening to the Gritty Nurse podcast. If you have any suggestions or want to hear a specific topic, email us at grittynurses@gmail.com. That's grittynurses@gmail.com.
We are also speakers and authors available for engagements related to advocacy, nursing, mental health, and health policy. Please connect with us.
We want to take a moment to express our deepest gratitude to our incredible sponsors. Their generous support has been instrumental in making our podcast a reality.
Thanks to their belief in our mission, we're able to bring you engaging content and connect with our amazing community. We're truly grateful for your partnership. Thank you.